Welcome back to my channel. This is Dr. Liliana Andrade, and today's topic is dizziness in the older adults. So let's get started. Dizziness affects up to 30% of adults over 65 and is a major contributor to false functional decline and decreased quality of life. Because dizziness is often multifactorial, our structured approach is essential for effective diagnosis and treatment. Balance depends on the integration of three systems: the vestibular system in the inner ear, the vision, and the proprioception, or the body's sense of position. Age-related changes in any of these can contribute to dizziness. Dizziness can arise from multiple causes, including benign paroxysmal positional vertigo, BPPV, triggered by head movements caused by displaced otolites in the semicircular canals. Vestibular hypofunction, like vestibular neuritis or Meniere's disease, associated with vertigo, imbalance, and nausea, often linked to viral infection or fluid buildup. Orthostatic hypotension, caused by impaired autonomic regulation, dehydration, or medication side effects, leading to dizziness when standing. Cardiac causes like arrhythmias and aortic stenosis can lead to dizziness due to reduced cerebral perfusion. Cerebrovascular disease like transient ischemic attacks and vertebrovascular insufficiency presents with episodic dizziness, weakness, or visual disturbances. Medications like antihypertensive, sedative, and polypharmacy in general contribute to dizziness through sedation, blood pressure fluctuation, or vestibular suppression. Psychogenic causes like anxiety and depression, patients may report floating sensation often associated with hyperventilation or panic attacks. Sleep disorders like sleep apnea and insomnia can contribute to dizziness due to chronic fatigue and impaired autonomic function. Nutritional deficiency, especially vitamin B12 and thiamine deficiency, results in neuropathy, weakness, and imbalance. A patient's description of dizziness helps narrow the differential diagnosis. Vertigo is described as spinning sensation suggesting vestibular dysfunction such as a BPPV, vestibular neuritis, or Meniere's disease. May be accompanied by nausea, vomiting, nystagmus, or imbalance. Episodes can last seconds in benign paroxysmal positional vertigo, hours in Meniere's, and days in vestibular neuritis. Presyncope is described as a near fainting or lightheadedness, often due to orthostatic hypotension, arrhythmias, or hypoglycemia. Patients may report visual dimming, weakness, or palpitations. Disequilibrium is described as unsteadiness, linked to peripheral neuropathy, Parkinson's disease, or musculoskeletal issues. Patients usually describe difficulty walking, veering to one side, or feeling off balance. Non-specific dizziness, described as a floating, giddiness, or brain fog, is common in anxiety, depression, or chronic medical conditions. Symptoms are often vague and persistent. A structural assessment includes history, characterizing dizziness type, onset, duration, triggers, and associated symptoms, as about falls, recent infections, new medications, or psychological stressors. Medication review is an important part of it. Pay special attention to antihypertensive, benzodiazepines, antidepressants, and polypharmacy in general. Physical examination, check for orthostatic vital signs and assess for hypotension. On the cardiac exam, look for murmurs or arrhythmias. On the neurological exam, check for ataxia, weakness, and cranial nerve deficits. On the vestibular test, always perform the Dix-Hallpike maneuver for benign paroxysmal positional vertigo. On the functional assessment, always check for gait and balance evaluation with the time up and go test and rumbar test, which can help to assess for fall risk. Management depends on the underlying cause. For benign paroxysmal positional vertigo, AP maneuvers is highly effective rather than the use of meclizine due to high anticholinergic side effect profile. For vestibular disorders like Meniere's disease or vestibular neuritis, the vestibular rehabilitation exercises improve balance. For orthostatic hypotension, increase fluid intake, adjust medication, and use compression stocking to improve venous return. When you suspect cardiac causes, refer for EKG, echocardiogram, or Holter monitoring to evaluate for arrhythmias and structural cardiac damage. For medication-induced dizziness, consider deprescribing or dose adjustments. For sleep disorders, manage sleep apnea and improve sleep hygiene. When you suspect psychogenic dizziness, cognitive behavioral therapy, SSRIs, and relaxation techniques may help. Is there a nutritional deficiency? Supplement B12 or thiamine as needed. Dizziness in older adults requires a comprehensive patient-centered approach. By carefully assessing history, performing a targeted exam, and addressing underlying causes, we can improve outcomes and reduce fall risks. If you enjoyed the video, please like it, share it, and subscribe.